Welcome, everybody. My name is Jenny Eklund. I'm Interim Head of Climate Health and Sustainability at NIHR. And I'm very pleased to see you all online today for this introductory collaborative pre-launch workshop on decarbonising the health and social care system, our upcoming funding opportunity, which is opening on the 27th of November. So thank you so much for giving us your time this morning. I'm just going to, before we start the main presentations this morning, I just wanted to give everybody a chance to join, because I know we've still got people joining online at the moment, and to mention a couple of housekeeping points before we get into the main agenda. So we have a lot of people online today. We're expecting about 200 people to join. So in some ways, it's quite ambitious to include a collaborative element, which you'll see from the agenda we do have a bit later on today, to enable you to speak to some of your peers about your emerging ideas. But it's something that we're really keen to do. But what that means is, for the first part of today's session, for the presentations that we're going to be sharing with you, we're all going to have our microphones off, please, just because there are so many of us. And then for the collaborative breakout sessions a bit later on, you'll be able to unmute and speak to your colleagues. We haven't included time after each individual presentation today for questions. Instead, we're going to have a question and answer session at the end. And we ask you, please, as questions arise, to put questions into the Q&A box in the Teams app. And my colleague Becky will pick up some of those questions at the end of the session, and we'll answer as many of them as we can. So I think we've got most people have been able to join now, so I think we can move on to the main part of the agenda. So I will start just by introducing the funding opportunity to you. This is the second one of these introductory pre-launch workshops that we've run. The first one was in London in person in September. I don't think we've got anyone online today that came along to that first workshop, which is good, because today's online version is exactly the same content, so exactly the same as those people who joined us in London in person heard. I will then pass on to Dr. Fanny Burrows, who's going to give you a bit of an insight into the research needs via the Greener NHS programme to start to inform your research ideas. At 10:35, we'll be joined by Professor Cliff Shelton, who will share an inspiring case study of decommissioning nitrous oxide use, so you can start to think about how your research can inform real-world carbon reductions across the health system. Cliff then takes the floor again with his colleague, Dr. Catherine Al-Zerbi, at 10:55 to give you some tips from Research Support Services, NIHR Research Support Services, on preparing your application. And then we'll have a breakout collaboration session, so the floor will be over to you for 25 minutes, half an hour, and you'll be joining breakout rooms with people who have similar interest areas to you. You very kindly shared those interest areas when you signed up for the workshop. You'll have time to explore that and to support your peers with some of the ideas that they're coming up with as well, perhaps even find some future collaborators for a future application. And then, as I mentioned, we'll finish with some questions, 11:50 at the end, and you're welcome throughout the presentations today to add questions into the sidebar. If you're just joining, please make sure that your microphone is muted. We'll just be taking questions written in the Q&A box rather than verbally today. Lovely. So let's move on then. This funding opportunity is, I think, really exciting. It's the first time that we've really provided a formal themed funding opportunity on decarbonising the health and social care system. It's something that NIHR has funded separately, perhaps in smaller ways through some of our other programmes, but this is the first time that we've really put the focus on this really important area. And it's really exciting to have so many brains in the same virtual room interested in working in this area. So thank you for joining. So we're all here to gain a bit of understanding of what to expect from that funding opportunity. It will be launching on the 27th of November. It's also an opportunity for you to hear some inspiring examples from Fanny, from Cliff, on how your research can really make a difference to this mammoth challenge of decarbonising the health and social care system and reaching net zero. It's a chance to learn a bit more about pulling together an application, particularly if you perhaps haven't applied to NIHR before, and an opportunity to make connections with your peers and explore potential topic interest areas together. The intention is to generate some really innovative, collaborative research and solutions that can be submitted as applications for further development or funding. So, in terms of context, I wanted to just give you a very brief introduction to NIHR Climate, Health and Sustainability, so our approach, what to expect in November, and some of the support that is available both in the virtual room today and over the coming months, which we really encourage you to take advantage of. What this session won't do is give you very detailed information on the themes and the scope of the brief, and that's because the full brief won't be published until the official launch, as I say, on the 27th of November, but it should give you enough of an indication of the kind of themes that you should expect. So if you've joined the session today, chances are you probably know a little bit about NIHR, but if you are completely new, NIHR is the National Institute for Health and Care Research. We're funded by the Department of Health and Social Care. We're the largest funder of health and social care research and training in the UK, and we work in partnership with the NHS, universities, local government, other research funders, patients and the public. And that partnership element is really important to how we work. We are also a major funder of applied health research in low and middle income countries, but this funding opportunity relates purely to the UK. So a bit of context then to this call. Climate, Health and Sustainability as a coordinated programme at NIHR is a little over 18 months old, and it draws together existing work across 4 areas. So we're looking at our operational footprint, so carbon footprint of NIHR centres, and we're establishing our baseline at the moment, how we best mobilise knowledge for climate, health and sustainability research through means such as NIHR journals and evidence, training and capacity, how we support researchers to develop their skills in this area and how we build the field, and also funding research, which is of course our main focus for today's session. NIHR's commitments to climate, health and sustainability were formalised in March of this year through a set of public commitments. If you're interested in taking a look at those, they are available online and they cover the next 2 years. And key to those commitments was a commitment that we would increase funding for health, climate and sustainability across these 3 areas. So these 3 pillars: human health, health and care systems and research systems. Of course, this opportunity relates to the central orange arrow, and that's an area that hasn't had much formal support in the past. So we're really keen to help build the field and excited to see what ideas you bring forward. So, expect. This will be a £25 million funding call over 5 years, and it will be split into 5 million a year. As I mentioned, the opportunity will open on the 27th of November, and it will seek to address urgent knowledge gaps across health and social care. We anticipate that a range of projects in size and scope will be commissioned where possible. So that includes developmental applications and more significant funding applications. We'll also be actively encouraging capacity building and training as part of this. So you'll be able to apply for between 10 and 20% of your application to be dedicated to capacity building. In terms of area of interest, it is fairly broad, and we've kept this deliberately broad, and you'll see when the scope is released in later in November. We're aiming to generate evidence to support decarbonisation of the health and social care system and build research capacity. There are some specific themes that have been identified in the draft brief, which you'll see, but we're keen that proposals are not limited to these themes. You will be, in many cases, much closer to the action on this. You may have some really interesting ideas that we have not picked up on, and we don't want those to be ruled out. Areas of particular interest, however, are likely to include developing sustainable health and social care pathways, reducing carbon emissions in healthcare through preventative care, innovations in diagnostic imaging and surgical services, empowering patients to manage their own health, and mental health. There are some things we're especially keen to encourage as well. Co-production, so collaboration with other disciplines, with other sectors, charities, local authorities, SMEs. We really feel, and I'm sure you feel this as well, that for such a vast challenge to decarbonise the whole system, it requires collaboration across areas that perhaps don't tend to work typically closely with each other. So we're really keen to encourage co-production. If you haven't applied to an AHR before, we very much encourage you to apply here. And patient and public involvement. This is something which is central to NIHR's approach. Again, if you have applied to any of our programs in the past, you'll be familiar with this. If you're not familiar with it and it's new to you, don't worry. There is an awful lot of guidance on our website, and you'll be able to speak to our staff about how to build this in to your study design. There is a new requirement as well, which is research inclusion as a condition of funding. So from November, this is something that every applicant will need to build into their funding proposal. NIHR recognises that research is not currently serving those most in need, and that research could do more to be designed and conducted inclusively. And in order to facilitate that, we're encouraging applicants to build inclusive research design into their applications and to specifically cost for inclusive design components, because we appreciate that it does require additional resource and additional thought, additional time. Some practicalities that it's a good idea to think about. This is a cross-programme NIHR opportunity. So again, if you've applied to an NIHR in the past, you might have been used to applying to a specific programme. This is different. It's across all of our programmes, and you will submit your proposal using a single application form. Further details, of course, will be provided, including the links on the 27th of November. You don't need to make a separate application to an individual NIHR programme or to specify where you think your research sits. I just wanted to draw your attention as well to some upcoming online sessions that we have. On the 12th of December, we've got a support session with Research Support Services online, and we have a second session on the 16th of January, which you'll be able to sign up to for some support from our colleagues once the funding opportunity is opened. And you'll hear from Cliff and Catherine later from RSS, and they'll be able to tell you a bit more about what they'll be able to offer you and how they can support. Other than that, the email address that you need is here, sustainability@nihr.ac.uk, for any guidance regarding eligibility, questions you might have after today that aren't answered. And I mentioned research support services. This is the email address you'll need to contact them for specialist support on your proposal development. I'm going to leave it there because I'm very keen that you get to hear from our other speakers today and start to become inspired and formulate your own ideas for a potential application. So I'm going to hand over now to Dr. Fanny Burrows from the Greener NHS programme.
Thank you, Jenny, and good morning, everyone. I'm just going to share my screen and really happy to be here today. And I wanted to give you a little bit of a background introduction of the Greener NHS programme and then give you some further ideas of the work we're doing around research within the programme. So I'm a senior lead responsible for research and innovation within the Central Greener NHS team and overseeing our research and innovation there. And this morning, what I'd like to do is give you a very brief introduction. I'm sure you're all relatively aware of what we're doing and why we're doing it. So I won't spend too much time there, but then I want to give you a little bit more information about the work we're doing around research and innovation. And then hopefully dig a little bit further into the area that we're interested in from a research perspective and finish with a bit of a case studies that showcase what we can do around research, the kind of barriers that we think are still in the way and how some have been, from our perspective, the work we've been doing to try to overcome these in a collaborative manner. So first of all, to start with, why the commitment to reach net zero for the NHS, and I think we're all well aware of the impact that climate change has on patient health and our health, and the avoidable death that we could have if we were to tackle this major issue. And there was a really interesting report that the Chief Medical Officer was available, I think, in 2022, that described the number of deaths just in the UK, for example, that are associated to air pollution. So a real kind of major threat. But also we know that climate change is disproportionately impacting those vulnerable population and therefore increasing the health inequality surrounding health and within the healthcare system. So yes, I think that the first message is very much sort of a major threat, and also to acknowledge the fact that the NHS, being a major employer, the largest employer in the UK, is a major contributor to those emissions, those harmful emissions, carbon emissions. So it's very critical on climate change. So we are part of the problem, but this major challenge, and to try to drive together better air quality for the population, but also try to sort of improve health, improve through, for example, active behavior and also healthier diets. So lots of opportunities from the healthcare system, from the NHS, to try to reduce the impact that we have on climate change. And there's so many different opportunities and solutions we can find in collaboration. But just to give you a little bit of an overview on the commitment, and I'm sure you're all really well aware already of this, we have published in a report in 2020 the two major large commitments that the NHS has of becoming net zero for the emissions we directly control by 2040. So anything like the electricity we consume on site, the sort of gas that we burn. And the second commitment is to reach net zero by 2045 for the emission that we can influence. And that's what we call the carbon footprint plus. And those are, for example, a major part of the emissions that come from our supply chain. And I'll show you the graph that demonstrates that really well. A major commitment, first healthcare system in the world to commit to this, and so it's very, very exciting. And also we were the first health system to embed net zero into legislation through the Health and Care Act in 2022. And in 2022, we also had every NHS trust and ICB committing to becoming net zero through publishing a green plan with a number of key actions to drive towards net zero and specific priority area. And sustainability was also embedded into the Care Quality Commission to try to look at the sort of regulation around how care is delivered and integrating sustainability into this. So some major progress has been made in this space, which is really lovely to see. Just very briefly, this is the kind of graph that I wanted to really show you. And you can see here on the right-hand side of this chart, the 62% here that come from the supply chain on the sort of scope 3 emissions that are part of the carbon footprint plus. And that can be any kind of non-medical equipment, medical equipment, medicines that account for 20% from a scope 3. But we also know, for example, that medicines account for 5%, this kind of 5% here, the direct point of use for anesthetic gases. And Cliff will give you more information on that in a moment. And there's also a good proportion here around the traveling of staff, of patients, of visitors to tackle. So you can see here in this chart some of the breakdown of those emissions we have in a healthcare system. And on the right-hand side, to actually acknowledge the fact that those emissions happen in every area of healthcare provision. So yes, we have a large carbon footprint in acute care, in secondary care, but also largely in primary care and actually across all NHS setting. So it's really important that we focus on decarbonising everywhere. Now, as a program, we've got lots of different area of focus, as you can imagine from having seen that graph of the emissions. Lots of work around the travel and transport and the behavior around that, but also our building and our facilities, how we reduce or maximize the energy that we consume to use, for example, renewable and be more energy efficient, but also acknowledging the fact that we've got an old NHS estate, so lots of challenges there. Research and innovation is the bit that we'll come into in a moment, but we also have a lot of work around the workforce and what training and education we need to provide for our workforce to deliver good and safe care, but in a more sustainable manner, and looking at the behaviour related to that as well. Lots of work around the supply chain and the procurement of whether that's medical or non-medical and medicines devices, and how we can reduce the emissions that we find in that supply chain. And also a lot of work on the data analytics. How do we gather and collect the data? How do we report it? How do we measure our progress and start to look at what are the other areas that we want to focus on? Lots of work as well around the food and nutrition, understanding that kitchens in hospitals are energy intensive, but also the food that we eat and where the food comes from. Medicines accounting for 25% of the carbon footprint, so lots of work around medicines at the point of use, but also in the supply chain, understanding those that are high in carbon, emitting in carbon, and trying to tackle those. And then a lot of work around the clinical transformation. How can we deliver safe care, efficient care with a kind of lower carbon footprint, and how we can transform our service deliveries. So these are the areas and a little bit of a background of the Greener NHS programme. But now I would like to focus a little bit more around the research and innovation space. And from a research perspective, we have lots of different opportunities. We're very keen to work with research partners on how we can collectively start to kind of stimulate collaborations and integrate kind of sustainability as a core principle across the research sectors and across the kind of research programs, and sort of foster those kind of key collaborations towards sustainable healthcare systems, but also sustainable health research systems. We're really keen to understand what are the kind of carbon intensive practices. We already know a lot, but we don't know everything and we don't know what we don't know. So kind of more evidence around understanding those kind of hotspots, carbon intensive practices. And also really interested into the sort of biomedical, clinical research and clinical trials. To have this understanding, we need to gather further evidence, and that could be generating new evidence, reviewing the evidence, reporting the evidence of those practices and interventions within the healthcare system. So then we can start to drive actions and interventions towards more sustainable healthcare. We're working very closely with different funding programs in the research and innovation space, such as the NIHR, to try to sort of support greener NHS priorities. And that could be here in the UK nationally, but also internationally, and lots of work going on there. Now, we're not going to achieve a greener NHS if we don't support the translation of this research into implementation, and hopefully I can give you a little bit more insight on that, but it's really important to think about the implementation at the start, how that research can actually translate into practice. And that's something that is really key for the research that we're considering today. And obviously, we need to engage with our patients and the members of the public throughout on research, performing research, but also research needs across. So really making that a key area. We've been doing a lot of work on trying to signal those needs that we've got within the NHS, understanding the research and innovation need and being able to signal them. And I'll give you a little bit more of illustration on that. But also trying to accelerate research opportunities. And today I'm really pleased to see this call opening at the end of November. But we've seen increasing funding in that space in the last few years. And it's really, really exciting to see these opportunities increasing. And for us, very sort of excited and enthusiastic about these opportunities to reduce the impact of the healthcare system on climate change. So really, really exciting to be able to try to accelerate research opportunities and try to have them quite targeted towards areas we know can have a huge impact. And then a key area is to stimulate the relevant collaborations. This is quite an emerging area around sustainable healthcare and really trying to sort of bring together the academic with the experts, with the clinical voice, with the patient voice together to try to make a difference and drive that kind of research into practice. And some key things that we're doing within NHS England, we've been doing a little bit of work on research needs and the sort of research needs across the organisation to drive a net zero NHS, and we hope to have something to publish next year around that. We've also been working to try to accelerate research opportunities very closely with NIHR, with UKRI on those opportunities, and we've seen a huge amount of funding going into this space. So it's really exciting to see that and then to see what comes out of these opportunities. And in terms of trying to sort of increase collaboration and making sure we've got the relevant partners together, we've launched this year our first conference on research output between the Medical Research Council at UKRI, the Green NHS Programme and the NIHR to try to showcase some of that research, but also bring partners together for opportunities to network, talk, meet, and create those really important collaborations. And we've also worked with a health innovation network, and in particular the UCR partners, on a program called Connecting for Change, which I hope to show you a video at the end to show you what can be done to try to build this collaboration and respond to real life NHS challenges. So now onto something important would be to try to sort of understand what are the key area of research that we're interested in as a programme. And this is to give you a little bit of an idea of some preliminary data that we've got, and I thought that'd be really interesting to share today, and some sort of understanding related to emissions within different clinical specialties. And we've tried to map that around activities and emission data to understand where carbon intensive practices exist per specialties. And these are still in a reviewing process. So this is not published data, but I thought that could be really interesting to show you where some of the big hotspots are across different clinical specialties. And as you can see, general medicines and general surgery, for example, together with trauma and orthopedic are kind of really high in terms of carbon emissions. But what's really interesting as well is to understand what within those specialties are associated with the kind of high carbon hotspots. And sometimes we think of travel being a big part of this, but actually travel in this kind of light purpley color is not as high. And sometimes what we found is obviously bed days are very carbon intensive, as well as some procedures in some clinical specialties. And actually in some other specialties, these are the face-to-face appointments with clinicians. So this is really interesting when we try to map where these carbon hotspots are and try to understand where we need to focus those interventions. And then to give you a little bit of an idea of where we can have this impact, and try to map that against those big work stream focus area within the program. We've got a big focus on the kind of moving towards lower carbon care models. And here we want to focus on generating evidence to understand where those carbon hotspots are, particularly focusing on high volume, low complexity area, which we know are burdensome. But also focusing on how do we implement those interventions in real world practice, but also have a focus on diagnostics and how we can move to sort of more preventative diagnosis and lowering the carbon related to diagnostics as well. We've got lots of work as well around digital and the digital infrastructure being carbon. We know that it's also carbon intensive and need to reflect on how we can have resilient digital infrastructure within the healthcare system that allows us to have resilient and efficient healthcare, but actually trying to think about the methodology we can use to understand the core benefit of digital and how we can improve efficiency, patient outcome, productivity, but also thinking about the environmental impact. And there's a key area on understanding what methodology we can use to understand the environmental impact of digital, the digital transformation, but also how we can make sure that we have resilient healthcare. And I think we've all heard of the heat wave in 2022 bringing a digital infrastructure down in a major London hospital. So it's really critical we think of the resilience and the climate risk associated to the digital infrastructure. There's lots of work we can do around the methodology and the data from a research perspective, understanding the kind of methodology that can capture this kind of health outcomes together with the kind of economic impact and outcomes together with the environmental and social impact. And how can we bring that together in the research and as key output to inform policy and to inform change. And also lots of research interest around product level footprinting. Behavior and workforce is a key area of research, and I think understanding how we can support the model shift at pace in the behavior of the patient and also the clinical workforce to deliver more sustainable care and approaches to care. And I think the real sort of system barriers around behaviors is really key from a research perspective. Adaptation is a key area of interest, and at the moment there's lots of work ongoing with an adaptation report, and we're really looking at the sort of how do we adapt healthcare system to the changing climate. And there's a lot of interest around how do we adapt our estates to heat, for example, but also the kind of cost effectiveness of adaptation strategy. But I think it's really important from a research perspective to actually integrate adaptation into the kind of mitigation action and to think of them together when we think of specific action. So that's a key thing for today that I also wanted to mention, is to try to think together that we're trying to mitigate the carbon impact of our healthcare system, but we need to also think about adapting to that changing climate that is a real thing, is happening. Estate and facilities I've mentioned briefly, but some areas of interest in looking at how we can have sort of smart, maybe looking at AI technologies to support adaptive healthcare, but also looking at how we use energy, how we sort of are more efficient in the use of our energy within estates, and potentially to bring innovation from other sectors into NHS estates that have perhaps been demonstrated in other sectors. So I think lots of opportunities there. Travel and transport, we know, there's a strategy that has been published, and I think a lot of research interest will be around behaviour of staff, of patients, of visitors, commute, to try to understand how we can move towards more sustainable transportation and behaviour supporting the sort of healthcare system. Around medicines, I think we've got lots of opportunities for understanding what our next priorities are on medicines. We focused a lot on anesthetic gases, inhalers, but what are going to be the sort of next priorities? What are the high emitting medicines being procured in the NHS? But also trying to sort of assess and identify those opportunities around sort of demand-driven emission reductions. And we're thinking of, research that would support things around reducing over prescribing in medicines, social prescribing perhaps is of interest, and other areas of change. So trying to really understand what are the next priorities, but also trying to focus on areas we know are high emitting. And then the supply chain obviously is a key area that we've got a policy of trying to reduce emissions through different milestones, and is trying to understand how the kind of research can inform the future strategy, and how can we try to bring further impact within the supply chain to try to understand how the evidence-based informed decision towards the kind of next policy and next strategy around sustainable procurement. And also how we can think about the value-based procurement. Well, how do we sort of need to sort of shift towards a value-based procurement, looking at the value of the product rather than just a sort of financial aspect of a product, device, or other equipment being supplied in the NHS. And that kind of links as well very well to circularity and trying to sort of find enablers or evaluate a reusable, remanufactured product within the healthcare system, and how can we safely introduce sustainable, reusable equipment and sort of improve patient outcome, but also environmental impact. So hopefully that gives you a little bit of an idea of some very high level research area. But the key notes here across all research is to really try to prevent unwarranted variation in care. And that's what I was mentioning earlier, is that kind of climate change impacting vulnerable population, and thinking about preventing an increase in health inequality in the research that we do, making sure that we engage with patients and involve a diverse range of the patient population to try to look at preventing that kind of increase in health inequalities. And co-production is really key here, to make sure that you bring the right stakeholders together to inform the research, but also to inform this implementation and translation into practice. So I think that's it for me now. Just wanted to thank you all for listening and for your time. I might not be able to stay until the end for Q&A, so feel free to send me an email if you've got any questions or want to follow up on anything. But I'll hand back over to Jenny now. Thank you very much.
Wonderful. Thank you so much, Fanny. And that's the second time I've had that presentation, and I still find it really, really interesting. And I think a really good way of setting us up for thinking about the next part of our session today. So I'm going to hand over now to Cliff Shelton, who's going to talk to us about a case study in detail on decommissioning nitrous oxide, just to give you a bit of an idea of how your research can translate into real-world impact. Over to you, Cliff.
Great, thank you very much. Can I just check that you can hear me and see the slides?
I can, and I'm hoping that everybody else can too.
What an excellent start. Okay, well, thanks ever so much for the introduction. My name's Cliff. I'm an anaesthetist in Manchester and a clinical academic at Lancaster University, where one of my jobs is to work for our NIHR Research Support Service Hub, which you'll hear more about from my colleague Catherine in a bit. But my contribution to this is going to be to share a case study about this gas that you can see on the screen. This is a cylinder of nitrous oxide, and it's already been alluded to in the presentation from Fanny that anaesthetic gases have been something that we've been interested in sustainable healthcare. And I'm just going to walk you through what we've done so far with this gas to give you an idea not only of some of the impacts that you can make, but how various different research activities that could be funded by a call like this one can make a big difference to the sustainability of our practice. So nitrous oxide is an interesting drug because it's one of a small group of drugs that is a greenhouse gas. And when we talk about greenhouse gases, we have to find a universal language to relate them to one another. And the way we tend to do that is using something called global warming potential. And what that does is it uses some mathematics based on some data to say, for instance, in the case of nitrous oxide, that if you were to release a kilogram of it into the atmosphere, that would be a bit like releasing around 300 kilograms of CO2 over a certain time period. This data is for 100 years. And this is for a couple of reasons. It's to do with the wavelength at which nitrous oxide absorbs and then re-emits energy, infrared energy, and also to do with how long-lived the gas is. So nitrous oxide, once emitted, lasts for over 100 years in the atmosphere. And you can find data like this from the IPCC, the Intergovernmental Panel on Climate Change, which tells you how much different greenhouse gases contribute to global heating. This is an old graph now, it's 10 years old, but it's nice and clear the way it displays the data. And you can see that carbon dioxide is far and away the most significant greenhouse gas. That's in the golden and orange areas, depending on where it's generated from. And then you can see methane in light blue, but then nitrous oxide is in the kind of royal blue color. So this is making a significant contribution to climate change. I should say that not all of it comes from healthcare. In fact, that's a minority. Much of it comes from agriculture and industry. So many of you on the call will be familiar with nitrous oxide as a drug. Most of it that gets used, I think, gets used in this context. This is my colleague modeling a demand valve for gas and air, or Entonox. I think many of us will have either had babies or had dental work and will be familiar with devices like this, where you breathe in, you get a lungful of gas and air, and then you breathe it out, and eventually it ends up in the atmosphere. But that's not the only place it's used. It's also used by us in anaesthesia. And in anaesthesia, in general anaesthesia, where we get somebody to go off to sleep for an operation, we have this concept called the triad of anaesthesia. And it's sort of a way of summarizing what we're trying to achieve when we give someone a general anaesthetic. Even though I said sleep just now, that's not really what it is. It's actually an induced state of sedation, which has to achieve these three things. So first of all, we want unconsciousness. Patients shouldn't be aware of what's going on. I think that's an obvious point. But also, we'd like immobilization, really hard for the surgeon to do their work and also for the patient to stay safe if they're moving around all over the place. And then the third thing is analgesia, in other words, pain relief. And even though during an operation, the patient couldn't be aware of being in pain because they're unconscious, if you put a scalpel into somebody's skin and they don't have any analgesia on board, you'll end up with things like their heart rate and their blood pressure increasing rapidly, and that could be unsafe for them. So nitrous oxide is both a sedative, it does a bit of unconsciousness, and a painkiller, just like I showed you with my colleague on the demand valve just there. And so historically, it's been used as part of a general anaesthetic technique. But over the years, we have found that there are alternatives that do the job of nitrous oxide, and in some cases do it just as well or even better. And so two alternatives which have become more and more commonplace are this drug, something called remifentanil, which goes in through a drip on the, along with, say, the fluids that are given to the patient. That's a drug that's a bit like morphine, but it's really quick to come on and really quick to go off. And one benefit that it gives you is a bit more control over patient's blood pressure, and another one is that it doesn't make the patient feel as sick after their operation. That's really important to patients. And then this is a little indication, little illustration of some regional anesthesia. So injecting some local anesthetic around the nerve or a group of nerves or just around where the surgeon makes their cut. And that can be really helpful because it means that you're targeting your intervention just at the relevant bit of the body, not giving something that acts on the whole patient. And that can be a bit more tailored to the patient's needs. So we can replace nitrous oxide with alternatives, and some of them have not only got climate benefits, but have got benefits to the patient as well. So the next question is, well, what happens if we do that? And this is a graph that I helped my colleague, Rishi Narayanan, to produce, illustrating the carbon footprints of general anaesthetics. In this case, it was for children. And in the darker lines, those are heavier kids. In the lighter lines, those are lighter kids. And the ones that are dashed are where you've got nitrous oxide as part of the technique, and the ones that are solid is where you haven't. And you can see that it makes a big difference to the carbon footprint that's attributable to an anaesthetic for a child. And the same results would be obtainable in adults as well. But that's not the full story, because what that graph assumes is that the clinical use of nitrous oxide is directly related to its emission. But when you really get into the weeds of how nitrous oxide is supplied in hospitals, that relationship isn't very close. So this is something called a manifold room, and this is R1 at Wythenshawe Hospital, or it was R1 at Wythenshawe Hospital before we got rid of it. And what you can see here is lots of different bottles of nitrous oxide gas attached to little bits of pipework that all feed into a central pipeline system. And that's the thing that you can see sort of disappearing off in all the different directions at the top. And this is unusual for a drug, that it's basically supplied like a utility, a bit like water or oxygen or medical air or electricity. And there's somebody whose job it is basically to make sure that the supply never runs out. And you can imagine that there are inefficiencies built into a system like that, particularly when clinicians are using it less and less. Now, one of the interesting features of this kind of supply is that unless somebody tells the people who are responsible for drug ordering and logistics that clinical use is changing, they might not actually be able to tell that they need to order less, and this truck might start turning up just as often as it always did. And even if that means that when the truck turns up, it takes back some, incompletely emptied cylinders, they don't just get topped up when they get returned to the gas manufacturer, they get released into the atmosphere. And the reason for that is that from a sort of regulatory point of view, these cylinders that are, maybe half full, maybe 90% full, are deemed to be a sort of opened medicinal product. And you can't just go around topping up people's bottles of tablets or tubes of steroid cream, for example, and it's treated in exactly the same way. So procurement, buying the cylinders in the first place, is the thing that inevitably results in their ultimate release into the atmosphere. So I'm going to share a video. Very heartened that Fanny's video worked really well, and I hope you can hear it. And this is a colleague of ours called Alethea Shakira. She's a pharmacist from Scotland, and she's going to tell you about how she sort of discovered the problem that I've just described, and then started to implement some ways of tackling it. So again, if somebody could let me know if the audio is failing to come through, then I can always do a voiceover for you.
Hi everyone, I'm Alethea. I'm Alethea Shakira. I'm a pharmacist, and I'm the head of pharmaceutical sustainability for Scottish Government. I'm also one of the co-founders of Pharmacy Declares, an environmental network for pharmacy practitioners, but I'm also the founder of the Nitrous Oxide Project. And it's here today. I'm going to just give you a whistle-stop tour of how the Nitrous Oxide Project came to be. So in early 2019, I took a job with NHS Lothian. Before I started, I undertook a literature review to understand where the big carbon emissions were for theatres. And I quickly realized the low-hanging fruit was actually the anaesthetic gases. So I set to work about dealing with that. I also it made sense as a pharmacist that I focus on drugs. So in addition to my financial reporting, I also embedded carbon stats within that. Now, this reporting had a real impact on the volatile footprint, but my nitrous oxide footprint, I was quite obvious, wasn't changing. So I knew I needed to drill down on that data and began needling it. And I made it part of my mission to work out what was going on. I wanted to know how the gas was supplied. I wanted to know how it was managed. I began to speak to porters, estate teams, QAS pharmacists. I began interviewing my anaesthetists more rigorously, asking them when they were using this drug, how they were using this drug, how often they were using this drug, and how much as well. So I started beginning to ask lots and lots of questions on the gas. So that was interesting. And then but around early 2020, I began to suspect we were looking at the wrong end of the horse. I suspected clinical use was very low, and what we actually needed to focus on was systems. And supply system, and I think I was, as it turns out, I was correct. To sort of help aid this work, I utilized the DMAC framework, which is part of Lean Six Sigma, and to frame this analysis, but also helps mitigate. So for those of you who aren't familiar with DMAC, it's used extensively in industrial process. It was originated in the car industry, but it helps eliminate waste, sort of both for time, labor, and materials. And this is quite important, especially when you're dealing with complex systems like medical gas supply. So Lothian would have eventually evidenced loss across 3 sites between the ranges of 83 to 100% per annum of system loss of total nitrous oxide. So I immediately contacted the Association of Anaesthetists and the then Sustainable Development Unit, now known as the Greener NHS. And they were great. They were really they helped escalate a lot of that work. But also my Scottish-wide analysis was showing that, using per capita of population density, that Lothian was quite normal. It was quite the medium. It was medium and the mean in terms of its anaesthetic nitrous oxide use. So I knew we had a Scottish-wide, if not a UK-wide problem, because we followed the same health infrastructure dictates. So luckily, I made contact with 2 great environmental fellows, Chris Allen, an anaesthetist, and Amarantha Fennell-Wells, a dentist. And in January, they helped me launch the nitrous oxide project to a wider UK and global audience. So by end of March 2021, I'd gathered system loss, anaesthetic system loss on data on 16 systems across the UK and 1 from Republic of Ireland. And I quantified system loss and waste of 13.7 million litres for these sites. Now, the biggest emphasis of my work has been aligning the supply of this drug to the clinical need. And this is really important. It doesn't really matter what supply you plump for. It has to align to clinical need, and it has to meet the needs of that particular site or clinical environment. That's very important. So this is now a worldwide initiative, and just to give a sense of what this looks like. So my first site, I unmasked loss of 790,000 litres. The worst site I've dealt with in the global arena is about 11 million litres from a site with really failing infrastructure. So just to wrap up quite quickly, our emissions in Scotland have dropped by 60%, which is great. But our analgesic nitrous oxide is also on the way down. We've dropped by 11%. We're just beginning the journey there. And we're doing lots of work to improve planned preventative maintenance as well as care of demand valves, because a lot of that loss happens well before it gets to a patient because of poor systems management. Thank you for listening. Lots to do, but I leave you here.
Okay, I hope you enjoyed that, and hopefully that's illustrated that.
Hi everyone, I'm Alethea.
Hopefully that's illustrated. A couple of things. First of all, this is all quite recent, isn't it? So 2020 was when Alethea noticed that problem. And secondly, just some of the crazy numbers. So, you know, between 83 and 100% of nitrous oxide that was ordered wasn't even being used. And if you ever needed a justification for why you should do multi-professional work and join up between people who have different aspects of a piece of knowledge, I think that's a really good example. So what does Alethea tell us that we should do? Well, we should go and check whether we're actually using nitrous oxide, and you can find that out from your anaesthetic machines. You should check your nitrous oxide manifolds and see how quickly are you turning over the stock. You know, do you have aging infrastructure? Is your pipe work leaky? You know, do you even know how much is in these cylinders? You actually have to weigh them to figure that out, and that's not routinely done. And so do you have evidence of a supply and demand mismatch? And how much is getting delivered and therefore taken away and therefore emitted to the environment? And you can see here the national impact. This is actually NHS England data, which is more available to me rather than Alethea's backyard of Scotland. But you can see that over time, the emissions of anaesthetic nitrous oxide have fallen, and there's a downward trend. But the way that this is actually happening is individual institutions are starting to decommission their nitrous oxide manifolds. Looking at those big cylinders that I showed you earlier on, if you sort of multiply the mass of nitrous oxide that's in those by their global warming potential, there's actually about 5 tons of CO2 worth of greenhouse gas in each one of those cylinders. And what does 5 tons of CO2 buy you? Well, when I first started doing this talk, it was a flight to Australia and back, but aeroplanes have got more efficient. So now it's a flight to Australia and back, and then back to Australia again. So this is really significant amount of greenhouse gas emissions. When we did the work that we've described at my hospital in Manchester, we found that for every 100 of those cylinders that we ordered, we only used one clinically. And so we were effectively flying to Australia and back and there again 99 times for every one time that we should have been. So we've decommissioned this manifold and replaced it with some mobile cylinders that you can wheel over to your anaesthetic machine and just connect at the point of use. And that's appropriate for somewhere that doesn't use this stroke very much. And these are the outcomes at our institution. You can see that when we look at how much nitrous we're ordering, it's fallen by 98%. Interesting, we don't actually save very much money by doing this, and this might explain why over-ordering is so prevalent. An organisation like the NHS will barely notice these small numbers in big hospitals like where I work. But this is the impact that it's had on our carbon footprint in Manchester. We've virtually eliminated CO2 emissions associated with anaesthetic nitrous oxide. Just before I finish, I'm going to show you one more talk. This is from somebody called Paul Southall, and he works for the Royal College of Anaesthetists, and he's going to talk about how all of this work has been translated into a national consensus statement.
Hi everyone, my name is Paul Southall. I'm an anaesthetic consultant in Worcestershire, and I'm one of the environmental advisors to the Royal College of Anaesthetists. And I was going to take just a couple of minutes to talk to you about my involvement in the nitrous oxide project over the last few months, and how we've managed to move from what was very much an estates and facilities focus towards a clinical voice on nitrous oxide and what we should do with it. You will have already heard about the very good work that's gone on over the last few years on the nitrous oxide project and its inception, based on the science behind it. And I just wanted to give a little snapshot of how we translated that into a clinical perspective and what we've done about the science behind it and the work that already had taken place. As you all know, probably already, a lot of the initial work that existed on nitrous oxide was around an estates and facilities perspective and quantifying nitrous oxide leaks. And that work was excellent, and I kind of started to ask a lot of questions about what we should be doing with nitrous oxide going forward. One thing that quite a few of us who work clinically had noticed, particularly within anaesthetics, was that there was a distinct lack of a clinical voice on what we should be doing with nitrous oxide and what the best thing to do about it was, because it was clear something needed to change. And I had the idea earlier on this year that we should try and translate some kind of clinical statement on nitrous oxide manifolds and the fact that there was an alternative that was much better, to try and move forward the rate at which the project of updating nitrous oxide use clinically was progressing. It tied in quite nicely because the estates and facilities toolkit was due to be updated at around the time that we were looking to write this statement. And that kind of became evident after a conversation with some people in NHS England that it'd be good if we could tie what we wanted to say clinically along with what was going to be updated from an estates and facilities perspective. So back in April this year, I started work on drafting a statement, which I'd hoped was going to be spread between anaesthetic organisations within the UK and Ireland to give a perspective on removing nitrous oxide manifolds. So the statement was drafted in April and shared amongst various organisations. We'd been given a rough timescale that the estates and facilities toolkit was likely to be updated towards the end of the summer this year. So we got a fairly tight timescale, which we didn't initially think we were going to be able to meet, to try and get it done at around the same time. So we effectively drafted a statement to say that pipeline nitrous oxide is no longer required in clinical practice, and that we can move to an alternative, which is point of use cylinders where required. That was written by myself and the Royal College of Anaesthetists, and we then spread that around to various anaesthetic organisations within the UK, and it was approved pretty quickly by all of them. And I think that's testament to the work that had gone on previously that quantified the issues with nitrous oxide and nitrous oxide leaks from manifolds, and it meant that the work could progress quite quickly from a clinical perspective. So that statement was written, shared amongst the various organisations and approved within 3 months. And it just goes to show that even though quite often sustainability work can be quite slow and feel a bit like wading through treacle, when the science already exists and is robust and backs up what we're trying to do, and there's a strong will amongst like-minded individuals to get the change to happen, we can get work done quite quickly, which is very reassuring, and I hope would set a precedent for future projects that we want to do going forward. So the statement was done 3 months, effectively, start to finish, and has so far had very good feedback and approval, both within these islands and also abroad in Australia and New Zealand, who are looking to mimic some of the work that we've done up here. And I think it's a very good example of how we've gone from the very early stages of the thoughts around the potential of being a problem with a drug, the science behind it, the initial thoughts from a states and facilities non-clinical perspective on what we should be doing with this drug, and the then subsequent acceptance and production of a guideline from a clinical perspective that has added weight to the work that started years and years ago, and hopefully will reach a natural endpoint where we change widespread practice worldwide based on an initial idea. Thanks so much for listening.
Okay, so there's the consensus statement. And he did say years and years ago, but actually it's 4, isn't it? It's from Alethea spotting this problem to Paul and his colleagues getting some national, in fact international, because Ireland's involved too, clinical guideline. And that's a really compressed timescale when it comes to these things. So just to wrap up then, what have I talked about? I've talked about a story that has gone from recognition of a problem through to national change in a fairly short period of time. And just to come back to the point of all of this, which is about different kinds of research that you all might want to do, here are the sort of some of the key publications, but some of the key methods that have been involved. So in the early mid-thousands, we started to cotton on to the importance of the sort of climate science around this. We've had randomized control trials that kind of bolstered the reason for using those alternatives. We've had service evaluation. That's Alethea Shakira's master's thesis just there, which you can go and read if you want. That was combined with some implementation science to think about ways that we could translate that into practice. We've had bits of policy, for example, from the National Health Service, bits of innovation to get those mobile cylinders working in practice. We've had some case studies which have also fed into the piece of work that Paul mentioned. I think I've spotted some UCL partners here who are working on those to tell us all how it's been accomplished elsewhere. And we've got consensus building. So that all of those methods have fed into this piece of work. And hopefully by listening to this story, you've spotted something a bit like this in your practice that you might be able to get your teeth into. Thank you very much.
That's great. Thank you so much for sharing that, Cliff, and also for sharing Alethea and Paul's stories as well, which I think really helped to bring it to life. I'd like to pass now to Catherine Alzabi from Research Support Services, who works with Cliff, who's going to talk you through the kind of support that you can look for from RSS. Over to you, Catherine.
Thank you. Can you see these slides all right?
Yep, you can see them fine. They just need to be full size. Perfect.
Great. Hi everyone, I'm Catherine Alzabi and I work as a Senior Research Fellow in Sustainability with the RSS based at Lancaster University. This morning I'm going to be talking very briefly about sustainability and research design. I'll give a brief overview of the role of the RSS, make some reference to the NIHR carbon reduction guidelines, and indicate some further resources that you might find useful. So the NIHR Research Support Service, or the RSS, provides free and confidential advice to health and social care researchers throughout all stages of the research process, from pre-application all the way through to post-award. It's a national service with 8 hubs, offering research methodology expertise with specialist centres for public health and social care. And to be eligible for support, you'll be a health or social care researcher based in England, applying for funding to NIHR or other national, open and peer-reviewed competitions. So before I describe our vision, I just want to make a quick point on language. So what do we mean by sustainable research? We mean it in the environmental sense. That is, avoiding the depletion or degradation of natural resources and reducing or eradicating greenhouse gas emissions. The overall aim of sustainability is to ensure what we do today doesn't compromise the environment for future generations. You'll also hear us use the term greener interchangeably with sustainability, and again by that we mean working in ways which are environmentally responsible. So our RSS vision for sustainability is firstly to support researchers in designing and conducting primary research studies that will lead to a greener health and social care system. And secondly, we also want to help researchers conduct all health and social care research in a way that protects our environment. And the way we'll do this is by highlighting to researchers key resources, such as the NIHR's carbon reduction guidelines, and we'll also be offering expert advice on integrating sustainable practices into research designs. We'll also support the development of sustainability-specific health and social care research. So, for example, through the discovery, development, and evaluation of innovative green solutions to health and social care problems, green evidence-based practices, as well as new green methods and technologies. And here's our fabulous sustainability research team, led by the wonderful Professor Cliff Shelton, who you've just heard from, and Cliff's a consultant anaesthetist and a professor of anaesthesia at Lancaster University Medical School. And then there's me. I'm an applied health researcher with a background in health inequalities and planetary health, in particular green social prescribing alongside children and young people. And then there's Sarah, who's a medical doctor with a background in population and community health, who also works alongside children and young people. And then there's Charlotte, who works with Cliff in the medical school, and Charlotte has a background in ethnography and interdisciplinary research, and she also has expertise on food production and consumption, as well as consumer plastics. So what support does the RSS offer? We provide support and expertise from a variety of methodologists, including statisticians, health economists, qualitative researchers, social scientists, behavioural scientists, and clinical trialists, and many others with expertise in research design and methods of analysis. We'll also offer advice and support on involving the public in your research design. As Jenny mentioned earlier, research inclusion is of the utmost importance to NIHR, and how to ensure your research is inclusive throughout all stages of the research process. RSS also offers support for building a project team, and advice and support are also available in areas such as research impact, approaches to dissemination, addressing feedback from funding committees, helping you to find other sources of support and advice, as well as identifying opportunities for collaboration. So when preparing your funding application, it's going to be really, really useful to read NIHR's carbon reduction guidelines, which consists of 19 key recommendations for researchers. The aim of the guidelines is to reduce carbon emissions, for example, by improving research design efficiency, transparency, and reliability. I'm not going to go through all 19 recommendations, but I'm just going to draw your attention to some. So firstly, make sure you've done the groundwork to involve patients and staff to get their views and feedback on the relevance, the importance, the feasibility, and the acceptability of your research question and design. Otherwise, it might not work, and that would be wasteful. And ensure that you've made full use of the existing evidence base so you know what's already out there in your respective disciplines and fields to avoid unnecessary reproduction. Next, make sure your study's been designed efficiently by making good use of resources such as patient time, and do seek to involve RSS methodologists in the design who'll be able to help you in any areas that you're not sure. Importantly, for research inclusion, when you're setting up and conducting your study, make sure to include and listen to advice from those directly involved in recruitment, such as patients, clinicians, VCSE staff, in order to optimize procedures for recruitment and retention so you can actually make the study work. It's also important to avoid unnecessary data collection, for example, by clearly setting out what you're going to be measuring and why, when it will be measured, and precisely how the measures will be used in your analysis. And for clinical trials, make sure your trial monitoring is sensible by focusing on issues that are critical for the safety and the well-being of your participants, as well as the reliability of your results. And avoid inefficient or ineffective monitoring practices, particularly those that require extensive travel to research sites. And in terms of good practice in reporting your research, make sure you contextualise any new primary research in the context of existing systematic reviews, and also ensure that research reports contain all of the information needed to make them usable and reproducible to others. And on reducing the environmental impact of your research, do ensure that your results and your outputs are rapidly and appropriately disseminated. And finally, where appropriate, consider assessing the environmental impact of any proposed intervention or changes in service provision. So I've included here a slide on some sustainability resources that we refer to regularly, which you might want to check out. These include toolkits from the Centre for Sustainable Healthcare and initiatives such as My Green Lab, the Green Theatre Checklist, and work on green air clinical trials led by researchers at the University of Liverpool. And finally, to access research support design with us at the RSS, you can register with us by completing a very short support request form, which can be accessed via scanning the QR code on the left here. And do visit the RSS website, and the QR code for the website is on the right. Thanks very much for listening, and I wish you all the very best with your funding applications.
Thank you so much, Catherine. That's really, really helpful. And I know that the questions have already been asked in the chat box, which my colleagues are very kindly answering as we go along, about slides. So yes, don't worry, you don't need to be furiously jotting down email addresses. We'll be sharing the slides later this afternoon. Okay, so that's the end of the presentation section of today's session.